anxiety and asthma. Obviously, just thinking about these two concepts, we can almost see how these two would be linked, where one can very much make the other a little worse and vice versa. So we'll go through the research as well as some theories, as well as what can be done to make sure that both are handled appropriately. I swear they usually don't take this long, but so yeah, the next transitions are quicker. So the objective.
Kind of making me anxious.
I know, right? I'm starting to get shortness of breath. So we'll be reviewing the prevalence and pathophysiology of both asthma and anxiety as separate entities, determine if there's an association between the two, discuss factors that influence both conditions and how they affect more so the pediatric population, and quality improvement to see what we can do to make our management and treatment of either of those two worthwhile and effective. There we go. So asthma, it's characterized by bronchoconstriction and inflammation of the airway, resulting in shortness of breath or wheezing. And as we all know, there are multiple triggers. These can be smoke, pollen, dust, diet, animal dander, scents, fragrances, and emotional as well as stress. It's a little bit of a diagram. On the left, we've got the normal airway, smooth, no muscle tightening. The airway lining looks clean, whereas in the asthma or the asthmatic bronchus, we will see muscle tightening, redness, inflammation of the lining, as well as mucus production, which we see often in asthmatic patients. So prevalence, and a lot of this research was done through the CDC. So even though it says 2011, yeah, the last, I guess, reported was from 2011 and 2013. So, and this is prevalence in the pediatric population. So 8.4% affected with asthma as of 2011. 1 in 10 children have a diagnosis, and that's as of 2013. It is the third leading cause of hospitalization in children ages 15 and under. It's responsible for about 10.5 million school days missed annually in the age range of 5 to 17, and this is as of the year 2011. And it's also responsible for healthcare costs of about $56 billion per year, again, as of 2011. This is just a little schematic about the common symptoms we do see and the triggers of asthma. You see the guy here holding an inhaler, which is one of the more common treatments for asthma. But yeah, on the top we see pollution, pet dander, dust, chemicals, mold infections, hereditary, as well as some food allergies, which may trigger an asthmatic response or a flare-up. So some criteria for asthma to be considered well controlled. The symptoms have to be occurring less than twice a week. Nighttime awakenings happening less than twice a month. They should not be interfering with any normal activity. Peak flow has to be greater than 80% of your personal best. Use of a beta-2 agonist, which is your typical albuterol inhaler, no more than twice a week. And exacerbations less than 1 time per year. And with this exacerbation, this pretty much means, have you gone to the ER because the asthma is so bad that it's not controlled? Now we move on to anxiety. So anxiety, as you guys all know, is it's actually a group of disorders characterized by excessive irrational fear and dread. Panic attacks is the main component. Episodes of sudden terror characterized by feelings of impending doom, and these usually last less than 10 minutes. Symptoms involve breathlessness, which is also hyperventilation, heart rate goes up, dizziness, just that feeling that you are no longer in control. Prolonged anxiety results in difficulty in controlling your levels of stress. This almost looks like a self-portrait of me, but... So now, what is the association between comorbid asthma and anxiety in the pediatric population? So emotional stress and anxiety are potential triggers for an asthmatic reaction. Children diagnosed with a diagnosis of asthma are 2 to 3 times more likely to develop an anxiety disorder when compared to their non-asthmatic peers. 8% of adolescents between the ages of 13 to 18 have an anxiety disorder, and 18% of that population has sought mental health treatment, which just goes to show how many have not. And so an undetected anxiety disorder still remains a big issue. So we have the cognitive theory perspective. The unpredictable and longitudinal experience with asthma attacks may generate fearful or catastrophic beliefs, provoking panic attacks and anticipatory anxiety. Obviously, if anybody has had an asthma attack, it can happen at any point. It doesn't usually give warnings, so it just kind of hits. So just living with that dread or that anticipation is enough to make somebody a bit more anxious about, oh, is this going to flare up my asthma? It can then be implied that living with an erratic chronic condition in childhood itself is a factor that is anxiety-inducing. Anxiety disorders may also follow an unpredictable course, often involving multiple factors during an episode. When combined with this volatile nature of asthma, it seems to become a vicious cycle. So I've broken it down, biological factors and then the next and the next. So we'll talk about the biological factors first. This one involves the autonomic nervous system. Now, this is part of our neurological system that is responsible for certain activities of the heart, whether it's speeding up the heart rate, slowing down the heart rate, but it is directly responsible for bronchoconstriction and regulation of emotions. So any dysregulation or anything that sets it off balance, as we do see in anxiety, is associated with an increased risk of bronchoconstriction, which we just saw a little bit earlier is one of the main pathways through which asthma flare-ups happen. So since bronchoconstriction is the primary mechanism of asthma, which results in dyspnea or shortness of breath, and use of a rescue medication like an albuterol inhaler, it's an overlapping symptom contributing to both to exacerbations in both conditions. Hyperventilation can be induced by strong emotions, which can then result in panic attacks. So these involve breathlessness followed by panic. So again, the primary symptom of asthma is shortness of breath or breathlessness, contributing to this vicious cycle. Just a little schematic about the autonomic nervous system. We see the sympathetic and the parasympathetic sides. If you look right in the middle, facial expressions, dry mouth, blood pressure going high, respiratory rate going high, heart rate going high. All of these are important mechanisms, that we see in both asthma as well as anxiety. So now, aside from the autonomic nervous system, we'll switch gears and go to airway resistance, another part of the biological factors. So studies have shown a notable autonomic response with increased airway resistance and decreased pulmonary function in response to emotional stressors in the asthmatic pediatric population. So if in terms of a stressful stimuli, 22% of participants in the study that I was referring to demonstrated significant bronchoconstriction due to stress induction. Next, use of beta agonists may also exacerbate symptoms of anxiety because not only, obviously they're beta 2 agonists, but they also act on the beta 1 receptors found on the heart. So a lot of times the inhalers or multiple frequent uses of an inhaler can actually cause increased heart rate. In that case, we often indicate that they may need something like Xopenex, which behaves a little bit differently so they don't get that increased heart rate. Next, asthmatic pediatric patients have higher levels of inherent airway resistance. So stress induction from anxiety results in subsequent respiratory compromise. So again, we're seeing that, they do perpetuate each other. Anxiety, airway resistance, and dyspnea, these are very common symptoms of both conditions. Next, we turn to the psychological factors, symptom perception. And this refers to the way in which an individual patient will report their experience of their disease-specific symptoms. And this is pretty subjective. If they feel like crap's about to hit the fan, of course, their symptom perception is going to be quite high, whereas somebody who knows what to expect, and if something is easily controllable, they'll be a little bit more laid back and their symptom perception won't be as intense or intensified. So studies were conducted on pediatric asthmatic patients and their anxiety levels measured during a methacholine challenge. So methacholine, just for some background, it's a synthetic medication used to induce bronchoconstriction and wheezing, which will simulate the symptoms of asthma. Results of this study indicated that the higher the baseline anxiety levels of a patient are, the higher their symptom perception will be, which follows a straight correlation, which makes complete sense. So it implies that the presence of anxiety in the pediatric asthma patient may lead to perception of worsened or more probably abundant asthma-related symptoms. The overperception of asthma symptoms puts the pediatric patient at risk for being overly medicated. And again, we talked about the adverse effect of the bronchodilators. They can also cause agitation and anxiety. For example, Singulair for some younger children has been known to cause anger issues or certain behavioral issues. So, same with inhaled corticosteroids, which usually are used for maintenance if the short-acting bronchodilator is not enough, can contribute to heightened anxiety symptoms as well. Next part of the psychological factors would be anxiety sensitivity. And this we define as the fear of arousal-related physical and psychological sensations. This will tell of a cognitive predisposition to experience increased risk of anxiety symptoms and panic attacks. This is an area where research is still ongoing, at least with the pediatric asthmatic population. This study it had done using the Childhood Anxiety Sensitivity Index, the ASI, which is a self-reporting tool to measure anxiety over the physical, cognitive, and social concern domains. High anxiety sensitivity scores in asthma patients have been correlated with comorbid anxiety disorders, another link between the two. Again, going on anxiety sensitivity, the Child Health Survey for Asthma, which is another tool assessing the physical, emotional, and activity limitations associated with living with asthma. So in these studies, we saw a negative correlation. As the pediatric patient becomes more fearful of his or her anxiety symptoms, their asthma-specific emotional health declines. This will give rise to increased feelings of isolation, anger, upset, and higher baseline anxiety levels due to the inability to effectively cope with their asthma. So very much so linked. The more anxiety surrounding somatic concerns that a patient possesses, the more likely they are to have poorly controlled asthma due to this overlap of symptoms between the two, anxiety and asthma. And as mentioned, unrecognized anxiety. And this is one of the main influencing factors. How can you know if there is a correlation if you are not diagnosing everybody with an as of yet undiagnosed anxiety condition? So it complicates the effort to attain asthma control as well. The airway changes occurring unpredictably in conjunction with these disorders may undermine the child's self-confidence in being able to manage their symptoms of asthma. Usually they'll have an impaired ability to sleep, poor concentration, and a decline in the decision-making process. And this is just a schematic talking about the biological, social, psychological factors and how they all combine to affect both anxiety control and asthma. For quality improvement, so what can we do to make sure that we are not missing one diagnosis or being able to effectively manage and treat both because they are very much so linked? So one would be improve the recognition rates of the underlying anxiety disorder in the pediatric population. Outpatient screening tools should be utilized. So for example, if they're done in the ER, false positives are likely. The ER is a very high pace, get them in, get them out type of environment. So, the findings cannot be accurate there for the most part. That's why outpatient is recommended. Then there's the SCARED screening tool, which is the screening for child anxiety related emotional disorders. It contains about 41 items screening for anxiety disorders in kids. Obviously, avoidance of triggers for both asthma and anxiety, and then early detection of the presence of an anxiety disorder in the pediatric asthmatic patient can help minimize the overmedication and unnecessary escalation of treatment, therefore improving asthma control. And I think I do mention this soon. The escalation of treatment, this also refers to like an asthma action plan. For example, if we see kids at the children's hospital, often whether they're admitted or not, they usually get an asthma action plan because let's say they're starting to have a flare up, they're on this medication. If it's not controlled, we then escalate the treatment and add an inhaled steroid. So that's kind of what they're referring to there. So pharmacotherapy and cognitive behavioral therapy, especially for anxiety, bronchodilators like a long-acting beta agonist or a short-acting beta agonist, inhaled corticosteroids, anticholinergic agents where they're indicated. So again, it's a step-by-step process. Research also shows that long-acting beta agonists used for asthma control is not really the recommendation, but at the same time, steroids would come second, short-acting beta agonists before that. So, and then asthma action plan, as I mentioned. Just a little schematic for cognitive behavioral therapy, as you guys are more than aware of. Thoughts create feelings, feelings create behavior, behavior reinforces thoughts. So if we can kind of help influence the thought process of our patients, then at least they'll be able to cope with even the unknown, or at least we would like to hope that they would be able to better than they are now. Any questions?